We have created short videos to summarize a book entitled Learning the Brainstem. The voice you hear is AI generated, as clear in diction as we can make it. LTB 17 completes the series as a whole. In this video, I provide notes regarding the arterial supply to the brainstem. I can only provide notes because there is much variability in how arteries supply the brainstem. Real anatomy looks like this. A schematic looks much cleaner. Let's walk through the numbers in this simplified image. Number 1 indicates the vertebral arteries. They are often asymmetric in size, as was true in the preceding real anatomy picture. 2 is the posterior inferior cerebellar artery, typically a branch off the vertebral. Only the left one is marked. 3 is the anterior spinal artery, which receives contributions from both vertebrals. At the point marked as 4, the vertebrals join to form the basilar artery. Where along the ventral surface the artery starts will differ from person to person. 5 represents the anterior inferior cerebellar arteries, but their vascular territory is notoriously variable and often rather small. And a unilateral anterior inferior cerebellar artery is common. 6 represents, I really should say underrepresents, many circumferential or penetrating arteries of the basilar. 7 is the superior cerebellar artery. Only the left one is marked. 8 is the posterior cerebral artery. Only the right one is marked. 9 is the posterior communicating artery, marked only on the right, which communicates with the internal carotid artery, marked as 10 in the left high brainstem. With the preceding arteries of the posterior circulation in mind, we can sketch territories of arterial supply. Again, however, I should caution that the territories are simply not invariant and there is much overlap. When it comes to strokes of the posterior circulation, however, one can more reliably say that vascular territories respect the midline. By the word respect, I mean that a right stroke will involve the right brainstem, even right up to the midline, without involvement of the left hemibrainstem. The lateral midbrain is supplied by proximal branches of the posterior cerebral artery. The medial midbrain is supplied by penetrating branches of the high basilar artery. Much of high pons is supplied by circumferential and penetrating arteries off the basilar, although some sources add that superior cerebellar artery can supply the lateral high pons. At the level of the facial colliculus in lower pons, the anterior inferior cerebellar artery, if it is present, supplies lateral structures, but circumferential and penetrating arteries supply the pons medially or even in its entirety. In medulla, I indicate 3 possible arterial territories. From lateral to medial they are the posterior inferior cerebellar artery, the vertebral artery, and the anterior spinal artery, most medially. A teacher of my own teachers in Boston wrote in the early 1960s that many so-called posterior inferior cerebellar artery infarcts resulted from ipsilateral vertebral artery occlusion. Historical descriptions of brainstem stroke syndromes introduce us to one guiding principle, as this image illustrates. What deficits might be predicted in so-called Weber syndrome, whose deficits relate to stroke or injury in the shaded yellow area? Answer: a left hemiparesis and a right oculomotor or CN3 palsy due to injury to the right cerebral peduncle, clearly well above the level of the decussation of the pyramids, and exiting fascicles of right CN3. I think there has been a general mistranslation of a French word used in an early description dating to one case in 1858. The author used the word alterne. English texts now refer to an alternating deficit that characterizes a brainstem stroke syndrome. But alterne really means, for example, a paralysis of one side of the body and the opposite side of the face. What constellation of findings might be expected from a lesion of this type, as described by Benedict in 1889? We can begin with a right CN3 palsy. But any of a variety of contralateral hemibody findings coexist. A left hemiparesis, because of involvement of the cerebral peduncle. A left hemiataxia, because of involvement of superior cerebellar fibers encircling the right red nucleus after the decussation of those fibers from the left side. And a left tremor or other movement disorder, perhaps due to involvement of the right substantia nigra. What about the syndrome in this instance, as described by Claude in 1912? Again, we would expect an ipsilateral CN3 palsy. We would also expect a contralateral left hemibody ataxia or tremor. Notice a pattern based on the last three cases, all in midbrain. Ipsilateral face, or some part of it, and contralateral hemibody. The eponyms and historical background are purely academic, but the pattern is clinically relevant. Ipsiface plus contrabody. Keep that in mind. But note that there are brainstem syndromes with bilateral findings that may be either symmetrical or asymmetrical. Nothnagle, working also just at the start of the 20th century, studied tumours rather than strokes, involving the tectum and dorsal tegmentum of midbrain. He noted bilateral oculomotor palsies, perhaps with upgaze paresis, together with gait ataxia that did not lateralize. In a related clinical constellation, sometimes termed a syndrome of the cerebral aqueduct, Parinot in 1883 described upgaze paresis in both eyes, bad enough that the eyes could look downward in the primary position, with deficits in accommodation and rather fixed large pupils, and a bilateral nystagmus with fast components in both eyes directed towards the midline, as well as other findings. Now let's return to our mantra related to brainstem stroke syndromes. Ipsiface contrabody. This slide summarizes various pontine syndromes with their associated eponyms and major clinical features. The overall pattern is what is worth the notice. Ipsilateral face plus contralateral body, whether an HP or hemiparesis or a hemibody sensory deficit. Seeming exceptions, based on the descriptions provided in the margins, are the two pontine syndromes in the bottom row. But what I did not add is that an ipsilateral facial sensory deficit due to involvement of the main sensory nucleus of CN5 happens in the dorsal high pontine syndrome, and an ipsilateral Horner's syndrome can occur in both high dorsal and ventral pontine syndromes due to interruption of sympathetic fibers that descend from hypothalamus. The ipsilateral ataxia in both cases relates either to involvement of the dorsal superior cerebellar peduncle before its decussation at the decussation of the superior cerebellar peduncles, or involvement of the ascending inferior cerebellar peduncle at the lateral edge of pons in both cases. So, here at long last is the last slide of the entire LTB series. The expectation might be that I would dive into the details of the Wallenberg or lateral medullary syndrome and the Dejerine or medial medullary syndrome. The upper MR diffusion-weighted image is a left Wallenberg and the lower MR diffusion-weighted image is a right Dejerine. Actually, I will not dive into too much detail for two reasons. First, after many years of teaching, it is rare that students remember even 3 components of a Wallenberg. And even if they did, they would miss how stroke syndromes have many, many variations, as is particularly true of a Wallenberg. Our textbooks are incomplete when judged against just seeing a lot of strokes. Second, one would miss the important principle, call it just altern. In a Wallenberg, as in the upper diffusion-weighted image, if you want to talk about a left Horner's and a left hemiataxia, then that would be lovely. By far the important concept, however, is altern, as the original French description used the word. The most common mistake that I hear is this, that a lateral medullary stroke involves a hemiparesis. Consider the big red lines that divide the hemimedullas in half on either side. The pyramids are nowhere near the lateral medulla. I would much rather have a student notice that an altern pattern of any type is an alarm to think about a brainstem lesion somewhere. The right Dejerine, the lower diffusion-weighted image, should involve a left hemiparesis and left hemibody sensory deficit, sparing the face, with rightward tongue deviation. But even a diffusion-weighted image, as emphatic as the one you see, does not reveal how the clinical picture was incomplete when we examined the patient. A subtle left hemiparesis and right tongue deviation were the findings of note. Oh, and one last point. If you were not sure of your location when this slide appeared just now in the video, if you had doubts about being in medulla, then not to worry. Just go back to LTB1. Special appreciation to those who endured all 17 videos in the LTB series. And indeed, as always, thanks for watching.